All right. Hi, everyone. My name is Sarah Trello, and I'm the Senior Program Coordinator for the Southeast Mental Health Technology Transfer Center's School Mental Health Initiative. And we are very excited to have you here for our session today, Medicaid Policy and School Mental Health Funding. We encourage you to introduce yourself in the chat box with your name, title, and location. If you have any audio or technical issues during the session, the chat box is open for you to communicate with our team so we may assist you. Also, if you have any resources that you'd like to share with others or any questions for our presenter, please enter those into the chat box as well. And before we get into the session, we do have a quick disclaimer. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policy of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Today's session is brought to you by the Southeast Mental Health Technology Transfer Center, or MHTTC for short, School Mental Health Initiative. We are located in Atlanta, Georgia at Emory University Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4 that you see pictured here. Our center includes faculty and staff with expertise in public health programs, finance, policy, and health systems, which provides us with a unique lens through which we can address mental health priorities in our region. The goal of our center is to accelerate the adoption of evidence-based mental health programs and practices by providing training and technical assistance to Region 4. And we do want to let you know that at the conclusion of this webinar, a link to an evaluation form will appear in the chat box. If you could please take a few minutes to provide us with your thoughts so we can continue to offer free webinars like this. And now I'm going to introduce you guys to our speaker today, Dr. Adam Wilk. Dr. Wilk is a health economist and a health policy researcher at Emory University's Rollins School of Public Health and the Health Policy and Management Department. He has 17 years of experience in Medicaid consulting, technical assistance, and research. Dr. Wilk's research focuses on access to care for low-income and underserved populations, particularly those with chronic illnesses, and state financing and policy related to providers' operations and care. And now I'm going to hand it off to Dr. Wilk.
Thank you very much, Sarah, and thank you all for joining us. It's a real pleasure to be with you all, and it's a privilege to have this time to speak with you all about Medicaid and school mental health financing. We do have an awfully full agenda today, so I'll be walking through our agenda quite quickly, as well as some of the details related to Medicaid billing and its requirements. So we'll start by providing you with an overview of our learning objectives, and then we're going to walk through the 4 primary requirements that have to be in place in order for Medicaid to be billed for a given service, with a lot of focus on school mental health services in particular. But then I want to make sure we have plenty of time to talk about Medicaid reform pathways and provide examples of relevant Medicaid reforms so that you all can get a sense as to how Medicaid can be modified in order to make it work better as a vehicle for financing of school mental health services in your state. We'll also have a few minutes for Q&A at the end. All right, so our learning objectives. By the end of this webinar, I am hopeful that you will all be able to specify when Medicaid can be billed for school mental health services. And if there are services in your community that are being provided but not billed, hopefully you'll be able to identify which requirements are not being met so that perhaps those could be modified going forward. I'm also hopeful that you'll be able to describe and distinguish the 2 main pathways for reforming Medicaid program reforms, for reforming state Medicaid programs in support of school mental health in particular. There are more than 2 pathways for reforming Medicaid programs, but I'm going to be spending particular time focusing on just a few of them. I'm also hopeful that you'll be able to identify and track down examples of other states that have pursued Medicaid reforms that might be pertinent to your circumstances in your state. I'll be pointing to lots of different resources along the way that I hope will help point you in the right direction. All right. So to get things started, I want to give us all a sense as to the range of experience that folks have with us today with respect to Medicaid and paying for school mental health services. So please select the option that best reflects your level of experience working with Medicaid to pay for school mental health services. Give you just a few seconds to select your best option here using the Zoom poll function. All right. So a good majority of us do not have any experience to date working with Medicaid to pay for school mental health services. But then we also have a range of folks with more than a year, between 3 and 10 years, and even a couple of folks with more than 10 years of experience in this area. I am hopeful that today's session will give useful information for folks all along the spectrum of experience. But I also want to draw attention to the fact that some of the details related to the 4 main requirements for service to be billed are also covered in other resources that we have prepared here at the Southeast MHTTC. And some of those we highlighted in an email that we sent out to all event registrants this morning. So if you're feeling at any point like you'd like some additional grounding in the fundamentals of Medicaid and school mental health, please take note of those additional resources and find the answers that are available to you and that may help answer your questions. But I will be reviewing quite a few of those details here today, so let's get started with that. And as I'm going, I'd appreciate it if you could all make use of the chat to help answer a second pseudo poll question here, if you like. And that is, what types of services are you currently providing that are not being billed to Medicaid presently? So I see you're all making good use of the chat to to give yourselves names and identities. That's great. But please make use of the chat to also identify what services you're currently providing but are not being billed to Medicaid. I'm seeing general behavioral health services and mental health therapy, trauma therapy on site at schools, school psychologist services, school-based therapy. Great. These are great examples. There's certainly some themes to what we're seeing here. I will take care to point out opportunities potentially to identify why some of these services might not be billable under the current policy regimes, which might be fodder for further discussion of potential reforms or innovations in program design, perhaps. All right, so let's dig into these requirements. Some of you may be aware that last year, our Southeast MHTTC published this report called Medicaid and School Mental Health Services FAQs. So we structured it as a frequently answered questions style document so as to make it very approachable for anyone with different levels of experience, really at anywhere along the spectrum, to get oriented to how Medicaid works, particularly in the context of school mental health services. The basic requirements that must be met in order for Medicaid to be billed for a service are covered in this report. And now I'll be dedicating some attention to each of them over the next several slides, while also pointing out some important nuances related to the contemporary policy environment. But just wanted to highlight in particular that this report is available for download. The link to it is now in the chat, and it's also available if you click on it in the slides that you've downloaded, or that should be available to you for download for this presentation. All right, so here are the 4 main requirements that have to be met when seeking Medicaid reimbursement for school mental health services, or in many cases, other types of services as well. They are, first, the service must be covered under Medicaid. Second, the recipient, the student client, must be enrolled in Medicaid themselves. Third, the provider must be a Medicaid certified provider. And fourth, the school must be an accepted setting under the Medicaid program in the state. There's a lot of variation across states in each of these requirements. I'll try to highlight a few of those ways in which states can vary. And so it's really important for you to be aware of what services are covered, what requirements are in place for enrollment, and so forth in your state. And I'll be trying to point you to where you can find that information in your state as well. We're going to start with the first requirement: Medicaid must cover the service. So Medicaid covers a range of services, including direct services, which we're most accustomed to thinking of, as well as some associated expenses for administrative services. Now, by direct services, I mean things like screenings and therapy and so on. There's a list of services that every Medicaid program must cover. Those are the mandatory services, including EPSDT, which I will come back to in a moment. And there's a list of optional services where it's up to the state to decide if they want to cover the service or not. Telehealth is a good example. But then there's also a set of administrative services that Medicaid can support, including, for example, conducting outreach and enrollment services for youth that may be eligible to enroll in the Medicaid program. Now, this process of billing Medicaid for these administrative services is often called administrative claiming, and that is the topic of a recent report. And I do mean recent, it's just come out within the last month or two. This is new guidance from the federal agency that oversees Medicaid, that is the Centers for Medicare and Medicaid Services, about how to think about the flexibilities afforded in the Medicaid program to seek reimbursement for administrative services. Again, things like outreach and enrollment services. So this new report is the first time that the federal government has issued new guidance about this process in 20 years. So it's been a long time coming. And they took care, I think, in reviewing this report to make it clear just how flexible they intend to be. So if you're in a region that is interested in expanding how often you seek support for the administrative services undertaken in your area, in your district, that support school mental health service provision, it would probably be worth starting conversations at your district or state level about what is the process in our state, and what additional flexibilities has the federal government made clear in this document that can be leveraged to further this activity. All right, but more generally, with respect to services covered in Medicaid, again, there's a lot of variation by state, since not all services are mandatory. States have some flexibility to choose which services they cover, and so different states cover different services. Now, where do you look for these lists of covered services? Well, most state Medicaid websites have a section that lists what they call covered services, or if it's more of a beneficiary-facing page, perhaps Medicaid benefits. But there should be a fairly clear list of services available somewhere, perhaps somewhere hidden in a section more intended to inform providers and administrators of healthcare institutions. But it's usually there. And I also want to bring up some fine print details here. So some services that may be listed in these lists may be covered only when billed with certain diagnosis codes. That is, they are intended to be covered only for individuals with certain diagnostic characteristics or having certain diagnoses. And then some services may be covered only with prior authorization. So this is more common in states that administer their benefits through Medicaid managed care plans, private plans administering benefits on behalf of the state. So in that case, certain services, particularly some higher cost services, those may be covered only if the plan has previously provided approval that the service can be provided and billed to the plan. That's what prior authorization means in this context. So there's some caveats there about when services will be covered. So here's a few examples of where to look on state Medicaid program websites. I looked on Florida's Medicaid website first and found that there is an explicit page called Covered Services and HCBS Waivers. We'll talk more about waivers in a bit, but the covered services list is pretty comprehensive, and I found it pretty intuitive to navigate. On the South Carolina Medicaid website, there's a page that allows you to download what is called their member handbook. And that document, which I understand is updated periodically, maybe quarterly, that document lists all of the services that are covered, but it's not posted directly on the website. So it may be available only in download as opposed to directly on the website, as is the case in Florida. Just as a few examples for where to look. All right, so I mentioned EPSDT before. This is the Early and Periodic Screening, Diagnostic, and Treatment Benefit. I mentioned it earlier in the context of mandatory benefits. That is, all state Medicaid programs must cover this. So there's no question. It's on the list of covered services in your state. And it's a really comprehensive benefit in a few different ways. For one, it covers many diagnostic screenings, services, and treatments. For example, autism screening, depression screening, tobacco, alcohol, and drug use assessments. So that's one way in which the EPSDT benefit is pretty comprehensive. So all of those services are covered. But then in addition, any need that's identified through these diagnostic services or screens can also be treated under the EPSDT benefit. That is, any services or treatments that it is determined are needed through one of these EPSDT covered screenings is also necessarily covered in Medicaid, even if that service is not otherwise listed on the list of services that Medicaid will cover. So EPSDT covers the screenings and anything identified as needed through those screenings. And in our impressions, that makes EPSDT a fairly underutilized benefit in Medicaid. So if you're interested in expanding the set of services that you're able to screen for or cover and bill Medicaid for, you can also expand the set of services, treatment services that get covered through this benefit without having to dig too deeply into the list of covered services otherwise. But because these services don't always show up in the covered list, I always like to mention EPSDT as a caveat to what I say generally about looking for services on the lists of covered services. All right, so that's the first requirement. Medicaid has to cover the service. So now we're going to move on to the second requirement, that the student client has to be enrolled in Medicaid. So in general, Medicaid is an entitlement program, which basically means if you meet certain criteria, you have the right to enroll. And there's two types of criteria listed here. One is categorical. That is, an individual has to be in a certain eligibility group in order to have the ability to gain coverage. And then the other is income-based. So within any of these categories, including both mandatory categories that are included in every Medicaid program and optional categories that states have the option to cover or not, there are distinct income criteria that must be met in order for an individual to be eligible. So you determine which category you're likely to be eligible for, which could include, for example, low-income children or children with disabilities. And the income criteria might be different for those different categories. The federal government establishes minimum household income limits for each eligibility category, but states can exceed those if they choose to make their eligibility criteria more generous. So there's lots of options for variation by state here. Certainly they could vary in terms of the categories that are covered and in terms of the income levels within those categories. So just to give you an example of an eligibility category that not all states cover, this is an eligibility group covered through so-called Katie Beckett waivers. If your state has a Katie Beckett waiver, it means that that low-income youth up to age 18 who require an institutional level of support for chronic diseases or disabilities and receive that institutional level of support at home, that group can be covered specifically through the Katie Beckett eligibility category. Not all states cover that group. All right, so that's one version of variation across states. And then again, I'll show you an example in a moment of how states can vary by income levels and their eligibility rules. So you can learn about your state's eligibility criteria and rules, usually on sections of the website that are geared more towards the beneficiary. There are links to apply for coverage and signals about whether an individual should expect to be eligible. And so that's where that information is usually covered. The fine print details I wanted to hit on here first, some individuals may be covered only with eligibility recertification every 12 months or sometimes more often. So basically what this means is that someone can be eligible 1 month and enrolled 1 month and then disenrolled and perhaps ineligible the next month. States require that individuals recertify their eligibility, usually submitting some documentation about family income with some periodicity, maybe every 12 months. Studies have shown that it is very common for individuals to have gaps in coverage because of these requirements. At least historically, though that wasn't always the case under the COVID-19 pandemic, which is a point I'll come back to. Now, some individuals may have income that is too high for them to be eligible for Medicaid coverage, and yet those individuals may still have eligibility for the Children's Health Insurance Program. Now, the CHIP program and Medicaid can often be confused for each other for different reasons. For example, sometimes they have the same name in a given state, but CHIP is a little bit different. Some of the eligibility rules and covered services can be different, And individuals can be eligible for CHIP sometimes at higher income levels than would make them eligible for Medicaid. So for low and middle income children, CHIP may be an option even if Medicaid isn't. So to give you an example of how this varies across states, we looked at the income limits for children in Medicaid or CHIP across the 8 states in our Southeast region. Now, in most of these states, individuals can be eligible for Medicaid if their family's income ranges between 213 and 255% of the federal poverty level. But Alabama stands out a bit. Their income limits are more generous, covering youth with family income up to 317% of the federal poverty level. This and more information about eligibility criteria in the Southeast region is available at the source with a link at the bottom of this slide. All right, so that's how states vary with respect to eligibility. Let's look at where to find more information about this criterion, this requirement in your state. So websites, again, Medicaid websites are a great resource for this. In Georgia, where I'm speaking to you from today, there is a section of the Georgia Medicaid website that gives information about how to apply and who is likely to be eligible when they apply for Medicaid. So that one's pretty straightforward. Kentucky has been doing some very interesting things with its Medicaid enrollment rules and protocols over the last few years, including blending its application processes for Medicaid and subsidies in the state health insurance exchange, which is called Connect. So it may be a little less intuitive to track down this information in Kentucky if you're not already aware that Connect is the name of the program that blends together application processes for Medicaid and the state health insurance exchange. So it may require a little bit of digging. It varies by state. All right, so I mentioned previously that eligibility recertification was a common issue that led to gaps in coverage prior to the COVID-19 public health emergency. But it was declared during the public health emergency related to the pandemic that states could not disenroll Medicaid beneficiaries even if they no longer qualified. So basically those recertification processes were halted during the COVID-19 pandemic, and there were no more gaps in coverage. But as of last month, the public health emergency was officially ended, and so states could now resume disenrolling individuals who were no longer eligible. And to my knowledge, 5 states, possibly more, have begun that process of disenrolling individuals determined to no longer be eligible. So we can expect that the frequency of gaps in coverage for individuals who might typically be eligible, that'll come back probably. Now, there could be some confusion about this in some states, particularly states where the rules are changing now. North Carolina is an example of this. The state recently approved Medicaid expansion under the Affordable Care Act, and so it's possible that with this end of the public health emergency, some people will lose eligibility because they are not currently eligible under current rules. And then once all of the final details are worked out about the state's Medicaid expansion, they could be eligible again and have to re-enroll without even changing their income. So disenrolled, ineligible, rules change, eligible. I could certainly imagine that being confusing for some folks. The rules are less likely to change for kids, but certainly we all know that family circumstances weigh on what's happening with the child. So watch out. The return of gaps in coverage is coming, and it'll be something that many districts and schools can potentially help youth with, particularly when doing administrative claiming for those supports. All right, let's move on to the third requirement, which is that the provider is a Medicaid certified provider. So there are 2 different pieces that govern Medicaid certification of providers in Medicaid in most states. So first, a provider must meet the state's licensure or certification requirements in order to be a practicing provider in the state, in accordance with their specific scope of practice. And then secondly, and this is an additional step, the provider must complete an application and provide some information to the state, which the state tracks in order to ensure that they are receiving bills from eligible providers. So providers typically are aware that they are or are not Medicaid certified. And so at the LEA level, if you're interested in working with a provider to bill Medicaid, it might typically be as simple as asking them if they are Medicaid certified in order to determine whether you think you will meet this requirement. Now, the rules vary by state as to which types of providers may be eligible to become certified and what the application process looks like. You can learn more about which types of providers may be eligible and what that process looks like, typically on provider-facing sections of state Medicaid websites. But again, another place to look is in your own backyard and talking to those providers that you might be partnering with in this. They should know if they are Medicaid certified most of the time. One key bit of fine print here is that some providers may only be in network, so to speak, with some Medicaid managed care plans and not others. So it is possible that a provider has completed the Medicaid certification process and yet may not be able to bill when providing services to a particular individual, a student, who is enrolled with a given Medicaid managed care plan because that plan and that provider may not have reached agreement, such a contract, such that the provider could be considered in network. So since many states, most states represented on our call today, administer many benefits for kids through Medicaid managed care plans, this is an additional wrinkle that's worth keeping track of. All right, so here are a few provider-facing sections of Medicaid websites that might be worth checking, again, to see what the certification process looks like. In Alabama, they call it a provider enrollment process, which I find a little bit confusing since we've already talked about beneficiary enrollment rules. So I'll continue to call it certification, but I just wanted to draw your attention to the fact that different states might call this process something different. And then in Tennessee, where benefits are administered pretty much exclusively through Medicaid managed care plans, they have blended the certification and in-network application process on the websites of the Medicaid managed care plans themselves, called 10 care plans in the state. So if you're looking for a separate place to become a Medicaid certified provider, you might come up empty and need to identify the page on the Medicaid managed care plan websites to become enrolled. And this may be the case that as to how it works in some other states as well. All right. And so then one other important nuance I wanted to draw folks' attention to related to this third requirement is that the employment status of the provider matters. The rules for Medicaid certification may differ for providers who are employed by the LEA or contracted to an LEA versus if they are a community-based provider. We're aware of at least some states where regulations may in fact prohibit LEA employed or contracted providers, mental health providers specifically, from becoming Medicaid certified and eligible to bill for school-based services when other providers, community-based providers, may be so eligible. So this may be an important opportunity for those states to check in with their state leadership and explore opportunities to reform Medicaid so that it might be a stronger support for school mental health programs where there are LEA employed providers. All right, so I'm going to pause here for a moment and ask you all to answer a question related to this particular nuance. Given that some of you have limited experience with billing Medicaid in your state, you may be best equipped to pick I don't know for this question, but for those of you who have some awareness of this, we're curious. Which groups of providers are eligible to bill Medicaid for school mental health services in your state? Are LEA employed providers eligible to bill? Are community-based providers eligible to bill? One, but not the other, or vice versa? Or are neither LEA employed providers nor community-based providers eligible to bill Medicaid? I heard in some of your chat comments earlier, some suggestion that LEA employed providers may not be able to bill for their services, or at least certain services in your state. So I expect that to be reflected in the poll questions here. Again, that might be an important opportunity for reforms in your state. To my understanding, it may often be the case that state plan amendments would be a useful vehicle for seeking the kinds of changes that we're talking about here. So consistent with what I was saying, I totally understand. Most of you may not be aware yet which types of providers are eligible to bill in your state, but I promise you it's an important detail to become aware of. And then for those of you who did not answer, I don't know, most of you answered that both LEA employed providers and community-based providers can bill. I'm delighted to hear about that. It may be that certain providers, that is LCSWs or therapists, may be eligible to bill if they are LEA employed, but other types might not be. So even if you're pretty confident that both LEA employed providers and community-based providers can bill at school in your state, it might be worth double checking that that is the case for all different provider types that you're considering working with. All right. So let's dig back into the last of the 4 requirements I'm talking about today, and that is that the school itself is designated a Medicaid accepted setting. So this is where we get to talk about the free care rule. So there's a bit of history here to be aware of. In 2014, the Centers for Medicare and Medicaid Services issued new guidance related to this so-called free care rule. And according to this new guidance, billing Medicaid for services in school settings is now permissible for students that do not have an IEP. And that is an individualized education program. And this is an important criterion for students who may be eligible for supports under IDEA. If that language is foreign to you, I would certainly encourage you to check out our IDEA related resources in our resource catalog. But for the time being, just know that with respect to the free care rule, it used to be that only students who had an IEP and had school-based services listed in their IEP could have those services billed to Medicaid. Now, with the new interpretation of the free care rule, Medicaid will cover school-based behavioral and medical services for students who do and do not have an IEP. It has always been the case, if the service is in an IEP, those services in their IEP will be covered by Medicaid, provided all of the other requirements I've been talking about are met. All right, so how states are doing right now, or what actions they've taken relative to this new federal guidance on the free care rule varies pretty widely, and I'll show you that on a map here in a moment. This is a map that was generated by the Healthy Schools campaign, who has done a lot of work to track what action states have taken concerning the free care rule and its implementation. Notably, different states may need to take different legislative or regulatory actions in order to implement this new free care rule guidance and make sure that all students who are enrolled in Medicaid can have their services provided at school billed to Medicaid regardless of their IEP status. All right, so what we're looking at now, again, are maps produced by the Healthy Schools campaign. The left map identifies states that have expanded Medicaid coverage in schools under these terms, and the right map highlights which states may be in the process now of expanding Medicaid coverage in schools. I would highlight, however, that this resource, as useful as it is and as much work as the Healthy Schools campaign has put into it, doesn't necessarily reflect what's going on specifically for mental health services. So I'll give you the example of Georgia, again, where I'm speaking to you from today. Georgia is marked in the left map as a state that has expanded Medicaid coverage under the free care rules terms. And that's the case because in our state, the state has taken action under a SPA, under a state plan amendment, to expand coverage to services provided by school nurses. However, if an LEA employs a mental health provider, a therapist or LCSW, their mental health services are still not necessarily covered when provided in schools. So when the Healthy Schools campaign resource identifies states that have taken action, just please note that this is potentially any action, not necessarily actions that open the doors to billing for school mental health services, which is our focus here. It's still a very useful resource, and I'll point to how in a few slides, but getting back to this issue about students with and without an IEP, it's a really important nuance in the context of this 4th requirement that school be a Medicaid accepted setting, because this requirement applies differently for students with and without IEPs. If the student has an IEP, school-based services in that IEP will always be covered, provided the other three requirements are met. However, the service may not be billable if provided by an LEA employed provider. Again, that's one of the other three requirements, and it's important to check it. That was requirement number 3. And if providers are not eligible for Medicaid certification when they're based at schools, LEA employed providers in many states, for many of those folks, that's the case. They may not be able to bill even for IEP covered services. So that's an important nuance to keep in mind. These requirements do play off of each other. All right, and a quick resource I wanted to draw your attention to. I went through those 4 requirements relatively quickly. And so for those of you who have less experience so far with billing Medicaid in the context of school mental health services, a little over a year ago, I gave a webinar presentation somewhat similar to this one that walked through those 4 requirements in a bit more detail, a bit more slowly. So I wanted to draw your attention to this webinar recording, which is available to you. It's posted in the chat now. Thank you very much, Josie. So you can click on that link and on your own time access that recording and learn a bit more about these basic requirements, the fundamentals of Medicaid and school mental health services. All right, but I do want to move on to Medicaid reforms with examples. To introduce this topic, I want to also ask you all to make use of the chat again. If you're aware of any changes that have been made related to the 4 requirements I've been walking through, or perhaps changes that may be underway, it'd be great if you could highlight those in just a few words in the chat. Our Southeast MHTTC is really anxious to learn more about these reforms, since we have a pretty keen focus on policy here in the Southeast region. And so we want to be able to dig more into those changes and provide information about what's going on to others. So please do make use of the chat to highlight any awareness you have of changes going on or that have recently taken place in your state. All right, so I made mention earlier of a key resource in this context, and that is the Medicaid and School Mental Health Services FAQs report. So that report has lots of different sections, but I want to draw your attention in particular now to a section called "What are the major types of Medicaid reforms?" So this section, it's about 4 or 5 pages long, walks through in some detail the topics I'm going to be talking through in the next several slides, including legislative changes, regulatory changes below the level of legislation, state plan amendments, and Medicaid waivers, as well as some key examples of these kinds of reforms in the context of school mental health, including under the free care rule. So let's dig into some of those more specifically. So let's start with an overview. Generally, the actors that we're talking about here who can be key in implementing reforms in Medicaid are state legislators and Medicaid agency leaders, often in partnership with leaders in education, behavioral health, or mental health departments, and so on. So these actors can reform Medicaid programs through passing legislation and making corresponding regulatory changes within the state, or by obtaining approval from the federal government for a state plan amendment or a Medicaid waiver. And then in some cases, the regulatory agency at work, the Medicaid agency, can make some rule changes without legislation or a state plan amendment or Medicaid waiver. It just depends on what sorts of regulatory freedoms are currently permitted. Now, in some cases, it's also important to note that a combination of these strategies may be needed in order to implement a given reform, particularly big ones like the free care rule. All right, so I want to orient you to why these different types of reforms may be needed. And this pertains to something called the hierarchy of legal authority, as we call it. So in any state, the highest legal authority is the state constitution. Nothing can violate the state constitution, not other laws, not rules and regulations. So when changes are needed, perhaps through legislation, the legislation has to be written in a way that does not violate the state constitution, because it is kind of hard to amend state constitutions, though it is possible. So these statutes that we're referring to here are laws usually enacted through legislative action. That is, the legislature takes action. So that's the next level down, the state statutes. And then below that are regulations, which are usually directed for change by state statutes. And whatever regulations can be changed, they cannot violate the state constitution or state statutes. So if there's flexibility in state statutes and the Constitution to enact certain regulatory reforms, maybe those can be enacted without changing statutes or the Constitution. But in other cases, it may be necessary to change the statutes in order to permit certain regulatory changes. All right. So let's go back to legislation first before we dig into regulatory actions. Certain kinds of changes can be made through legislation. Notably, legislation may be necessary to remove restrictions on possible reforms that might be undertaken by other agencies. And it can also grant the Medicaid Office Authority new authorities that it didn't previously clearly have to implement reforms. So in some cases, courts may rule that the authorities are not entrusted to the Medicaid office to impose certain reforms, and legislation is necessary in order to grant that authority. So here's an example related to school mental health. About 8 years ago, California passed legislation that removed previously existing restrictions that prohibited LEAs from billing Medicaid for certain targeted case management services when given to children without an IEP. So the law was necessary, the legislative change was necessary in order to allow for regulatory changes to be made that ultimately allowed LEAs to bill. So in this case, legislation was needed in order to allow for regulatory changes that ultimately made this kind of billing possible. So this is a multi-step process in California for reference. All right, so another option is the state plan amendment. In some cases, these can be done without legislative change. But in order to know what this is, you have to know what a state plan is. So the state plan is a contract, basically, between the state and the federal government about how the state would administer its Medicaid program within federal guidelines. So this state plan can be amended, but only with federal approval. Now, certain kinds of state plan amendments are done pretty regularly. That is, the federal government's pretty ready to approve those, but others are a little bit more nuanced. But also, notably, the federal government works with these all the time. Many states, in fact, submit state plan amendments for approval multiple times per year. So there's usually some authority, some office within the Medicaid agency that is pretty accustomed to doing these. And these kinds of state plan amendments can often be critical for making changes to rules for determining Medicaid eligibility, though in many states those rules are also written into statute. States can also change which services are covered and other reimbursement rules through SPAs, so they're called. If you're interested in making these kinds of changes, it may be important to get in touch with the Medicaid department, the Medicaid agency department that handles these. All right, so Massachusetts is a good example of this. Massachusetts did not have laws or statutes on the books that prevented schools from billing Medicaid for services like physician services or respiratory services. But rather, there were certain restrictions on the types of services that could be billed to Medicaid in the state plan. And so it was necessary for Massachusetts to seek state plan amendments, and they finally got one approved in 2017, that now allowed schools to bill for these services, physician services, respiratory services, and some mental health services. I'm highlighting this example, though, because it is an example of a state that did not require legislative action in order to make these kinds of changes. And there may be other states, including your states, where this is the case as well. All right, so a third pathway to Medicaid reform is the Medicaid waiver. So while state plan amendments can only be used to make changes to things already listed in the state plan, Medicaid waivers are another federal approval process that allows states to actually deviate from the federal Medicaid requirements, to bend the rules a little bit and explore innovative program designs. Now, that allows Medicaid waivers to speak to a wider range, potentially, of reforms that may be useful for advancing comprehensive school mental health systems in your state. But the rules that govern whether the federal government can approve a request for a Medicaid waiver are different. In particular, these Medicaid waivers have to abide by some standard of cost neutrality. That is, they cannot add to the state's costs, or the federal government's costs for that matter. And that's something that would have to be verified through the approval process. So Medicaid waivers and state plan amendments can be used in tandem with each other or with other reforms in order to enact big reforms like those for the free care rule. So I want to walk through a few free care rule examples here, highlighting some states that might need to implement just a single reform or multiple different types of reforms, or in some cases, no reforms on this level in order to implement the free care rule. So Florida is an example that required multiple reforms implemented between 2016 and 2020. So this state started with a process of seeking a SPA, a state plan amendment, to remove reimbursement restrictions on school-based services for students without an IEP. Now, that wasn't sufficient in Florida in order to allow for reimbursement for those services for those individuals. Rather, they also had to seek legislation, and they passed it in 2018 to take effect in 2020. So those efforts removed both state plan level and statutory restrictions in order to implement the new guidance of the free care rule. Kudos to Florida for making it through that process. South Carolina, on the other hand, didn't have to do nearly quite so much work. The state plan and statutes in South Carolina contained no restrictions relevant to the free care rule. So in fact, as of December 2014, when the new guidance was issued, LEAs could immediately begin implementing the free care rule aligned billing practices without having to lift a finger or ask that of anyone at the state level. So kudos to South Carolina for being so fortunate. There's a wide range between South Carolina and Florida's experiences, and so most of you will be somewhere in the middle. But figuring out which specific reforms are necessary in your state is the essential task. And the Healthy Schools Campaign resource is, again, a useful resource for gathering lots of information about what actions have been taken in your state related to the free care rule and what additional actions may be necessary. So this is a third map that the Healthy Schools Campaign has prepared that highlights states that have not yet taken action. Again, this is specific. This is not taken any action and may not be specific to mental health services. So again, Georgia is grayed out here, but if we were to prepare a new version of this map that spoke to free care rule related action states have taken specific to school mental health services, they would be filled in this map as a state that has not yet taken adequate action in order to leverage the free care rule guidance. But your state, if it's flagged here in this map, could be flagged for many different reasons. It could be that the state has not made it a priority yet, in which case engaging in communication with leadership may be appropriate for drawing attention to the importance of the free care rule for billing for Medicaid in your state. Or it could be that this Healthy Schools Campaign resource is not yet fully updated to reflect ongoing efforts. So it really is incumbent on you all to take a look at this resource and look at their state-by-state information, and then also look into additional contexts at the state level to learn how things are really working in your state and what steps might need to be taken next. But I, again, would highlight that this Healthy Schools Campaign resource, the link is available in the slide here, contains a lot of useful information about what has been done already, including information on covered services and behavioral health services, among other service types. All right, so with a few minutes left here before we get into Q&A, get your questions ready. I wanted to highlight that many of the resources that I've highlighted in the presentation here today, and many others related to financing and school mental health services, or related to other topics, they're all highlighted here in our Southeast MHTTC resource catalog. It's pages and pages of resources. We've tried to be deliberate about organizing them so that they can be really useful to you. And we want to strongly encourage you to take advantage of them. They are all free, and we hope they are very valuable to you in expanding comprehensive mental health services in your community. To highlight one specific resource that's very relevant to the content I've been speaking about today, there's a short report that speaks about SPAs, that is state plan amendments, and Medicaid waivers as vehicles for expanding school mental health services in Medicaid. So I walked through some of this detail today, but there's additional detail in this short report that may be useful for you in pursuing certain kinds of reforms in your state. And here's a few other relevant resources. I mentioned the webinar Medicaid and School Mental Health 101 earlier, again, which could be very useful for providing some foundational knowledge about how Medicaid works in this context. I could also draw your attention to a webinar I gave a couple of years ago on the financing of school-based mental health services in the context of Medicaid managed care, which does throw a few wrinkles in related to the requirements I spoke about earlier. And then there's an infographic on administrative expenses and billing. Administrative claiming is the term I used earlier. And then finally, late last year, I led another webinar that guides participants through a wide array of resources, including many that are otherwise listed in our resource catalog. So if you'd like to be oriented to many different resources that might help you with meeting different needs in your community, you might want to check out that webinar as well. All right, so with that, let me open the doors to a few minutes for Q&A. I'm seeing also in the chat, there's an opportunity to start providing feedback on this webinar. We'll give you another opportunity to click on that link in a moment. But in the meantime, please feel free to include your questions in the chat here, and I'll see what I can do to answer them. Otherwise, I will look out for anyone who might be raising their hand among our participants here. All right, thank you, Sarah. You've highlighted a question that came from Nakia Hudson earlier about what services are covered. Just to clarify, how is this differentiated from behavioral health community partners providing services to schools and billing Medicaid? So great question, Nakia. Thank you for bringing it up. There's a few different points that are relevant there. One, you're distinguishing between behavioral health community partners, that is, providers not employed by the LEA directly that you may be partnering with, and how the rules may be different for them versus LEA employed providers. And then there's the setting where those services are provided. So community-based providers can bill Medicaid always for services that are provided in their clinic settings, right? But if these services are provided in the school setting, different rules may apply. In many states, we have heard, they have seen success working with their Medicaid agency and community partner providers to set up shop in the schools on school grounds and provide services in person on school grounds and bill Medicaid for those services. But at the same time, if that provider were employed by the LEA, there may be restrictions in place preventing them from billing Medicaid for the exact same service. So it may be essential in many states in order for LEA providers to bill Medicaid for those services to set up equity provisions where LEA employed providers and community partners can likewise bill Medicaid for those same services. So there's a few different pieces there. It's the provider has to be certified as an eligible provider, and they have to be eligible to bill when they're delivering services in school settings. Not to mention, in addition, of course, the services have to be on the list of covered services, and the individuals receiving services have to be Medicaid enrolled. As always, all requirements have to be met. Okay, if there are any other questions, we may have time for maybe one more. Oh, great, thank you, Stephanie. I see your question. What are your thoughts on pursuing a waiver with CMS for services provided by a master's level school psychologist? Currently to be reimbursable by Medicaid, services provided by a doctorate level school psychologist, must be required. Exactly. So the rules related to which providers are eligible to become Medicaid certified, including to bill services at schools, are an important requirement. That was the third requirement I spoke to earlier. And some of those rules are specific about the training that the providers have to have in order to become Medicaid certified. Master's trained versus doctorate level training may be a key distinguishing factor. So that is an issue that Medicaid offices typically don't handle directly, so much as they partner with state medical boards and licensure and other agencies responsible for licensure or certification at the state level. And I am aware of some states where Medicaid has worked productively with those agencies or medical boards in order to expand the set of providers who might be able to gain licensure or certification when providing services in certain settings, for example, at schools. So it may be appropriate, Stephanie, for you to look into where is the specific restriction preventing master's level providers from administering those services or billing Medicaid, and seek out whether there might be some potential partnership arrangement that could be reached between Medicaid and the Department of Education or these medical boards and licensure authorities. That is something that other states have had success with. So there may be other examples out there that you can look to for guidance as well. All right. We should wrap up at this point. And again, I do want to ask you all for your assistance with providing feedback. Sarah, would you mind leading us through that exercise?
Yes. So as part of receiving SAMHSA funding, we are required to submit data related to the quality of this event. We ask that you please just take a moment to complete a brief survey about today's session. After you complete this session, you will be redirected to a second survey that includes additional information our center likes to collect to continue to improve the quality of our trainings and make sure we are addressing the needs of stakeholders in Region 4 through our programming. We greatly appreciate it if you take an opportunity to complete the second survey as well. And thank you all for attending today.
I'll second that. Thank you so much, everyone, for joining us. And if there's any additional support we can provide to you or any information you can provide us that might help us learn better how this works in your state, maybe we could learn from that and provide some of that guidance to additional states. We really appreciate your outreach and contact. And all of the work that you do in support of your communities and students. Thank you all.